Well, thank you for inviting me to speak on this subject this morning. I'm going to give a little bit of background to where I'm coming from, and then address some of the factors to consider when prescribing and monitoring antiretrovirals and some approaches to addressing polypharmacy and minimising toxicities. So I work in a large teaching hospital, a large HIV outpatient clinic, where the pharmacists are a part of the multidisciplinary team and are involved in seeing patients to start and switch treatment and make those treatment decisions and conduct medicines reviews and answer queries from patients and staff. And so where you work may be different, and you have different people doing those kind of roles. In terms of the background to polypharmacy and HIV, I'm sure that you're all aware of the key things, which are that compared to people of the same age who are HIV negative, people with HIV have more comorbidities, higher rates of polypharmacy, often around 10 years earlier than people who are HIV negative, and greater frailty, all of which leads to an increased risk of adverse events and drug interactions. If you'd like to read more about the subject, there are two really excellent recent reviews which cover this subject in great depth, and I would thoroughly recommend. So where to begin when we're thinking about preventing toxicity? Those of a certain age will remember Donald Rumsfeld, the US Defense Secretary, who was largely laughed at for this quote that he came out with a number of years ago. And except that when I was preparing this talk, it came to me that actually this is really what we're dealing with sometimes. We have the known knowns. So these are the patient factors like their age, their renal function, their comorbidities, possible side effects, which we know about from the summary of product characteristics. And then we have the known unknowns, things that we know that we don't know. So we don't know which side effects the patient will experience, even though we know the range of possible side effects that are likely. And then there's the unknown unknowns, the things we don't know that we don't know. And so these are things like previously unreported side effects, or undiagnosed comorbidities, or undisclosed medicines or substance use. And those are things which make it much more difficult, obviously, to predict or prevent. So it's largely the first two categories that we will be focusing on. So these factors, so patient factors, I've mentioned things like age and kidney and liver function, also genetics. Perhaps in time there will be more to do with genetics that we'll be able to use to predict people's responses to medication. But in HIV, we obviously have the example of HLA B5701 positivity being associated with an increased risk of a Bacavir hypersensitivity reaction. So those are things that we can take into consideration when we're selecting a drug or considering what might be a toxicity. And then there are other drug factors. So the pharmacokinetics, how it's handled by the body, the pharmacodynamics, drug interactions, those adverse effects that have already been reported, and the number of person years experience, which is particularly relevant for thinking about some longer term toxicities. So for example, when we have drugs that have been around for long enough and used in enough people, then cohort studies such as the DAD study are able to identify if they are associated with an increased risk of cardiovascular disease, for example, whereas the newer drugs that haven't been around for as long or used in so many people, we don't yet have that kind of data. And then there are comorbidities, so other things that might affect how the person responds to their antiretrovirals, but also due to the other drugs that they're taking for those conditions. And then there's non-medical substance use. So that includes things like complementary therapies, but also alcohol, tobacco, and illicit medicines, anabolic steroids that people use for in the gym. So a whole range of things which people may or may not disclose to us. And clearly, the more risk factors that there are for something, the higher the probability of toxicities. And perhaps a good practical example of that is when it comes to thinking about drugs which prolong the QT interval. We know that the more drugs that you have, or the more risk factors there are for having prolonged QT, the more likely it is that it will be clinically significant. And so the same kind of principle applies here. And so this slide is an example from our clinic, the Silver Clinic, which is a joint clinic between the HIV consultant and care of the elderly team. And this table on the right, and apologies if the text is too small for you to read, but it's just really to highlight where these patient factors come in. So, on this summary of the clinical characteristics of the patients who'd attended that clinic, we've got some patient factors such as their age. We've got some comorbidities, so in green, so we've got the average number of comorbidities was 7. And then also number of people with osteoporosis and osteopenia. And then non-medical substance use like smoking, recreational drug use, or heavy alcohol use. And then in yellow, polypharmacy. So the median number of co-medications in addition to ART here was 9. With a range of 1 to 15. So all of those factors that I mentioned in the previous slide, very much things that we see in everyday practice. So what do we do when we are preparing to prescribe or are reviewing a prescription? So I would suggest the first thing is to identify the relevant factors and then think about how significant they are for that individual patient. Then to think about which are modifiable or preventable. So for example, with lifestyle changes or by choosing a different drug, whether that's antiretroviral or something else. And an example of that might be where you've got somebody with osteopenia and there might be a question about whether the best course of action would be lifestyle changes or to change their antiretroviral. What monitoring is required? So we obviously, especially when people start treatment or are switching treatment, we're looking to pick up toxicity as well as monitoring to see how well everything is working. And with the non-antivirals, we're also looking for the same thing. So if somebody's on an antihypertensive, we want to know it's working, that they're on an optimal dose for it. So thinking about what to measure and when. And then integral to all of this, discussion with the patient to ensure that, that we have all the information that we need to make these suggestions and that they know what to do, what to look out for, when to call for help, and how to do that, including out of hours. And so that they go away with a clear plan of what to do and knowing what we're going to be doing as well. So a couple of slides on some practical interventions that we have done as a pharmacy team in Brighton. So the first was the Think ARV initiative, which was to publicise amongst our primary care colleagues, so general practitioners and nurses and pharmacists working in GP practices, that we had a mobile phone that they could contact us on, and hopefully get sort of real-time a response if they have a query about prescribing for somebody who's on antiretrovirals. So we sent these stickers with this capsule logo on, which they could put on their computers. And we have written this up, and it's due to be published shortly if you're interested in more details. But this summary slide here just shows the fact that that as a result of, or in the time period after this intervention, we received significantly more queries from primary care about drug interactions. And although most of them were safe, most of the medicines were safe to prescribe, we did identify significantly more red and amber medicines that shouldn't be prescribed or should be prescribed with caution. So thus preventing potential issues. And then the other initiative, which has also just been published with the reference below, was the Moore study. So the picture on the right is the Medicines Optimization Review Toolkit, and this was used as a basis of to conduct structured medicines reviews, and we compared that with standard care and found an increased significantly increased number of medicines-related problems that were identified and resolved in those people who had medicines reviews. And here on the left are the steps that we go through. So medicines reconciliation, the term that's used to mean essentially gathering all of the information that you can about what medicines the person's taking from whatever source is needed. Then checking for drug interactions, looking to see if any dose adjustments are required, establishing any issues from the patient, whether that's to do with toxicity or difficulty swallowing the medicines or the number of times a day they're having to take things, and then reviewing the indication or the need for each and attempting to optimize the way that people take their medicines and understand what they're all for. Now, we did this as HIV pharmacists, but since that time, there are now more pharmacists in primary care, and it may well be that the way forward is to have some kind of partnership between HIV pharmacists and primary care pharmacists to support the review of patients' medicines and optimizing their treatment. There are a number of widely available tools to facilitate appropriate prescribing and deprescribing. Some of them are listed there on the left, and you're probably familiar with some of them, particularly things like the Beers criteria and stop and start. On the right is a website, an online interactive tool, which is new to me, and I haven't used it in practice yet. But which looks potentially quite useful in being able to rank the need to consider stopping medicines based on these three factors. How likely is it that the drug's going to improve symptoms? How likely is it to reduce the risk of future illness? And how likely is it to cause harm in this particular patient? So those are things that you may like to check out. I think it's fair to say that polypharmacy and overprescribing are issues that are not unique to HIV, and they're also not unique to the UK. The review that I mentioned at the beginning of the talk by Edelman has come up with some very similar recommendations. Recently issued report from the Department of Health and Social Care on reducing overprescribing, and the key points being the importance of shared decision making with patients, providing better guidance and support for clinicians, not thinking of medicines as the only answer, and doing more structured medicines reviews, particularly for those with long-term health conditions. And finally, I think key to everything, whether it's preventing and identifying toxicities, addressing polypharmacy, or just overall patient care, remembering the partnership that we have with the patient as pharmacists, nurses, and doctors, as well as with each other, is at the heart of all we do. Thank you.